you. What a great way to come into this. On the back of the positive side of Malcolm's talk, what we find exciting, well, you saw the case that Aman and Abdul Rashid did earlier on. The gradient in an instant went from 60 to 0. The left ventricular ejection fractions, a few seconds later, doubled. Think back in your life, when have you last seen this? I never saw this. Even with STEMI, you don't see that. So it is an exciting time to be in interventional cardiology, but it does come at a price. So I thought we should look at 4 types of complication, case-based, and here's an 84-year-old female. Let me orient you here. So you see obviously the TAVR valve, you see the pigtail catheter for contrast injection for deployment, and you see here a temporary pacing wire, rapid pacing to deploy the valve. So watch this and see if you can figure out what went wrong. This is an old XT valve, and that's not good, right? That is not supposed to happen. When we do a valve, we normally pull the pigtail back, but what happens if you pull the pacing wire back by mistake? It stops pacing, and now you have an inflated valve, the ventricle contracts, and that gets embolized, an old valve. But the problem was human factor engineering was inadequate. There was a femoral pigtail right next to it, the femoral pacing wire. The lights are off. Instead of pulling the pigtail catheter, the assistant pulled the pacing wire. So the solution to that is simple. Hide the pacing wire. So from that case, 11 years ago that case, we now cover every pacing wire, so no human is able to pull that pacing wire. The second thing we do is we use the radial for the secondary access, not the femoral. Now, unfortunately, despite us covering it up, there's still occasionally the pacer fails. You see a PVC, another failed PVC here, and now this valve also embolizes. This is a more recent a failure of pacing to capture here. It looks like maybe it's stable. Unfortunately, you can see it's not in the right position. It embolized all the way around. We tried to post-dilate this and push it into the vessel wall. It's still unstable. One option to fix this is to put a thoracic stent graft in, had to put a 26 French sheath, but it did stabilize the situation. The patient needed a femoral surgical repair, but went home just after a few days. So it can still happen even with that human factor engineering. This is a self-expanding valve. You see it's embolized over here. An old case, but it can still happen, and it can be anchored with a second valve placed over here. This is a stable situation. So complication 1 is embolization. You've seen the risks. The prevention is test that pacer for a long run. Make sure there's an adequate drop in cardiac output. Hide it from humans and use the radial instead of the femoral as a second access. Okay, case for complication 2 is an 83-year-old woman. TAVR was placed, and immediately she developed chest pain, hypotension. Echo, which we have available, immediately shows a pericardial effusion. See if you can figure out what's happening. So here's the valve being deployed. Did you see what went wrong? Look at it the second time. Look just under the left main coronary artery when the valve is deployed. So you see the valve is being deployed. Now look where I'm pointing here. In 1 second. Pop. You see that? This is aortic root rupture or annulus rupture. And why? This was an oversized TAVR valve, excessive root calcification. It's an older case. We see this very rarely nowadays. We use a slightly smaller valve than we used to. In this case, the patient survived. She had a pericardial drain, went immediate to cardiac surgery, had surgical root and valve replacement and a long hospitalization, but she did survive. Unfortunately, this is a case obviously, this is a much more complex case. You see a massive root rupture, a big aortic dissection flap over here. This patient, who was much older, didn't even get considered for surgery and unfortunately did not make it. Another case. This was tamponade after TAVR. The aortic angiogram was normal. Can you figure out what's going on over here? There. This is ventricular rupture. So if the aortic angiogram is normal, immediately go out to do a high-quality left ventricular angiogram. We debated what the cause of this was. Was it the delivery system? It could even be the AL1 diagnostic catheter that can poke into that ventricular wall. Regardless, it was a serious complication. This patient did manage, without going to surgery, a long, active pericardial aspiration, auto-transfusion with a cell saver, and 4 hours of aspiration. This did seal down, and the patient did not need surgery. So we have an algorithm for management of pericardial effusion post-TAVR. The very first thing you do two things. You call the surgeons and save an operating room. You call for colleagues and you get a pericardial kit in place. Scrutinize that deployment angiogram like I show you occasionally. We'll see the root dissection and then a high volume, high quality aortogram. This is not the time to save contrast. 40 at 20. If that shows a root rupture, you've got to figure out one of those three things to do. If there's no root rupture, a high volume, high quality LV angiogram. If you see a perforation, decide how you're going to manage it. If you don't see any problem at all, look at all three things again. You'll probably see something. If all of those are negative, maybe it's the right ventricular pacing wire that caused the perforation. But this algorithm, if you have it in your cath labs, this will save you those precious 30, 60 seconds that might potentially be life-saving. So here's a third case. I'll have you look at this CT and see if you can figure out what the problem is. Here's a left coronary artery. And you'll see now the right coronary artery coming in, just there. And now you'll see what the problem is. I'm not going to tell you. Some of you will see what the problem is over there, and it's not the aortic valve. So this patient has the valve placed here. This is a relatively recent case, and immediately developed chest pain. And the echo said, wow, there was 0 MR at baseline, but now there's severe mitral regurgitation. If you look at the angiogram, we see the right coronary artery is not occluded, the left coronary artery is not occluded, but we don't see the circumflex. And that's because this was, as Aman showed you earlier on, an anomalous circumflex artery. Left main here, right coronary artery here. If you go more inferiorly, you see the circumflex origin and this retro-aortic circumflex. And now we see why the patient was having chest pain. This is the anomalous circumflex that's occluded because of compression from the TAVR aortic valve. You can see this on IVUS. This is the case here. You'll see systolic squeezing. I hope you can appreciate this systolic squeezing of the retro-aortic circumflex. This is a relatively straightforward fix, a multi-purpose guide, balloon angioplasty, a long stent, and a good result, immediate resolution of symptoms and mitral regurgitation because of systolic squeezing of the retro-aortic circumflex. That's an unusual situation. Normally these patients we will send to surgery. There were reasons this patient didn't go to surgery. I think the error in this case was not to place a guide catheter and wire at baseline. That should be done when you have a retro-aortic circumflex. This is a more common situation of coronary complication after TAVR. And here, this is a valve-in-valve TAVR. If you're ever going to do a valve-in-valve TAVR and you see that this is a trifecta or mitral flow, this should give you a tachycardia. This is a high-risk situation because these two surgical valve types have the valve leaflets sutured onto the outside of the frame. So there's no protection. So when you put a TAVR inside it, these valve leaflets are unconstrained and can press over the coronary ostia. The other risks are low coronary height, a narrow and low sinotubular junction, and a virtual valve to coronary distance of less than 4 millimeters. This was one of those high-risk cases, so we had a guide catheter and also a stent in place in the left main coronary artery, in the distal LAD here. So the valve is being deployed. There's an undeployed stent over here. Just in case we have coronary occlusion, we can pull this stent back and deploy it to open up the left main. So here the valve is deployed, and the patient is having chest tightness, and this is the angiogram. What do you think? It looks a little bit concerning. Maybe this leaflet is pressing on the outside, but the flow is brisk. This is a dilemma. What do? Well, we did an ECG. Here's the baseline ECG, and this is the ECG now. I think this looks ischemic. A little bit ischemic compared to just one day earlier on. Here's an IVUS. And you look closely, now you see here that one frame of severe compression, severe obstruction of the left main over here. So here we did pull a stent back, deployed the stent, got a good result, immediate resolution of chest pain. So this is chimney stenting because of obstruction of the surgical valve leaflet over the left main choriostomy. And this is important for everybody, not those who just do TAVR, because this can cause symptoms 1 week later or 1 year later. If you leave this, there's a risk of secondary thrombus, secondary scar tissue causing angina myocardial infarction and even sudden death. So everyone should be aware of that. And here's the before stent. This isn't perfect, but it's certainly an improved flow into the left main after stenting. So the risk factors for coronary occlusion we've talked about. Prevention is key here. In a high-risk scenario, we would still choose surgery. You can think about a chimney stent as an option. There are leaflet modification techniques that are advanced we won't talk about today. Heaven forbid if it happens to you, potentially there's an option for immediate surgery, ECMO, remove the TAVR and bypass. PCI can be very, very challenging. There is a few cases described of going in with 2 snares and pulling the valve out of position just to release that obstruction. We've never had to do that, but that is one of the options you can keep in your back pocket. So the final complication I will show you, even those of you who have not done TAVR have seen enough today and yesterday, and I see if you can figure this out. I hope you never have this situation. So that was the valve being deployed, and immediately, 3 to 5 seconds later, pulseless electrical activity. I'm going to pause because the answer is right there. All right. This is the valve, this is the case that was done. And this is a regular valve from earlier that I showed you. The valve is upside down. The valve is upside down. Valve reversal during preparation. So we have extremely experienced industry representatives put the valve together for us. This was a case, again, it's human factors. Later that same day, this same rep had a mitral case. And so she was thinking probably about the mitral, because you make the valve the other way around for the mitral case. So you go into auto mode, they made the valve the wrong way around. Now my colleague did this case, a young guy, genius, brilliant guy. He immediately recognized this as the problem. Immediately recognized this and got a second valve ready, put the second valve in place. So the treatment here was CPR, and I think you're doing CPR, but the valve is closed. CPR against a closed valve. So he put in 2 pigtails to prop open that valve, did the CPR. 4 minutes or so later on, a second TAVI was deployed. The patient was dismissed. No neurologic deficits. His wife said, you know what, he's even sharper than he was before. No comment, but he did just fantastically well. So I'm going to close by saying TAVR is different to every other procedure we do in the cath lab. There's a rule that pilots have called a sterile cockpit rule. This is true in all of aviation, where when you hit 10,000 feet on the descent, there's no non-essential talking. You're not talking about the cricket. You're not talking about the last case. Only essential talking. And we have that rule at Mayo in the cath lab. We have a TAVR safety checklist for every single case. Before we put the valve in the human, the tech reads out the following and has to hear an answer before they allow us to proceed. And the final one we added after that case, consultants, is the valve orientation correct? And I'll close by saying that if you do this, sterile cockpit, safety checklist, consistency, algorithms and protocols, I guarantee you that will save you some heartache down the line. And with that, thank you for your time.